Can you hear me?
Yes.
Okay, great. So yeah, hello everyone. Thanks for joining this webinar organized by the International Society for Neurovascular Disease, or ISNVD. My name is Yulen Ji, Professor of Radiology at NYU Grossman School of Medicine and the current president of ISNVD. ISNVD is a nonprofit professional association and is dedicated to the dissemination and the review of the new concepts and research ideas related to neurovascular disease. We have regular annual scientific meetings and hold workshops and webinars. This is our second COVID-related webinar. As we know, COVID-19 has not only made a significant economic and social disruptions in the past almost a year, but also has a whole range of health effects from the virus infection. And this pandemic is still going on. Today's webinar will focus on COVID-19 and the neurological complications. Thanks to the speakers and the webinar chairs. And now Dr. Paolo Zamboni will give an overview of this webinar. And Dr. Zamboni is one of the founders of the ISNVD Society and is a professor and the chair of vascular surgery at the University of Ferrara in Italy. Dr. Zamboni, please.
Thank you, Yulin. Good afternoon, good morning, depending from the latitude to everybody. Today, the meeting will be chaired by a couple of fantastic scientists. Marcella Lagana, who is the main researcher of the MRI lab in the Gnocchi Foundation in Milan, and Erika Menegatti, who is actually an assistant professor of techniques and technology applied to medicine at the University of Ferrara in Italy. What are the rules of the game today? Basically, we have 2 sessions with 2 speakers each. And at the end of each session will be 15 minutes discussion animated by experts, but everybody may interact by the means of the Q&A window of the Zoom platform that you may find in the bottom of your screen. So, a nice work today, a very interesting and cool topic. So I give now the word to Marcella Lagana.
Thank you, Professor Zamboni. So I introduce Dejan Jakimowski, who is a research assistant professor at the Department of Neurology, University at Buffalo, where he received his PhD degree, and clinical research unit director at Buffalo Neuroimaging Analysis Center. His research interests span from cardiovascular, environmental, and genetic risk factors in multiple sclerosis, and use of quantitative multimodal imaging techniques in predicting disease outcomes in MS and other neurodegenerative diseases. During the last 5 years, he has published over 70 scientific papers. Now I leave him the word for his lecture about the emerging data regarding the risk and outcomes of COVID-19 in subjects with multiple sclerosis. Thank you, Dejan.
Thank you, Dr. Lagana. So today we're going to talk about the COVID-19 and multiple sclerosis patients. We're going to try to understand if multiple sclerosis patients are at greater risk of contracting the virus and the disease. Are they at greater risk for more severe outcomes? And we're going to explore some considerations regarding future potential vaccination of this immunosuppressive group of patients. So to begin, multiple sclerosis, it's the most common neuroinflammatory and neurodegenerative disease, which is affecting up to 1 million people in the United States alone. and 2.7 million people worldwide. Typically affects the young, active, and working population, which is causing a great burden to our society. However, in the past 30 years, improvement in diagnosis and MS management, including approval of more effective disease-modifying therapies, has resulted in a significant epidemiological shift towards having an older MS population. And with that age, this population carries increased risk for cardiovascular and other age-associated comorbidities. As we all know, in the early December of 2019, the first few pneumonia cases were reported out of unknown origin, and they came from Wuhan, the capital of Hubei in China. Later, it identified that the novel enveloped RNA beta coronavirus has caused this disease. Now, as we all know it, corona disease 2019 or COVID-19, as I'm going to refer it during the talk. The diagnosis of COVID-19 is commonly being made through PCR testing and identification of the virus itself. And on the table 1, we can see several risk factors for the general population we're talking now that are associated with more severe outcomes and severe COVID-19, including older age, chronic obstructive pulmonary disease, type 2 diabetes, cardiovascular diseases, obesity, and chronic kidney disease. Lastly, immunocompromised patients are particularly vulnerable to this disease, and it's going to be mentioned throughout this talk in terms of our multiple sclerosis patients. So multiple sclerosis patients have been shown to have increased risk for infections. This is due to their treatment with immunosuppressive therapies. And both the largest 2 databases of the United States Department of Defense and the UK database of clinical practice have shown that MS patients have twice higher risk of hospitalized infections when compared to non-MS patients. Similarly, a Swedish MS registry has analyzed 8,600 episodes of up to 6,500 patients, and has shown that MS patients are stratified based on what DMT or disease-modifying therapy they're being treated with, by having the lowest rate of infections with interferon beta and glatiramal acetate, and highest rate of infections with treatments like the off-label use of rituximab. And this difference between the normal general population and the MS population stays true even after adjusting for all clinical and demographic factors. So as you can see here in the figure, multiple sclerosis patients that are treatment on rituximab, approximately half of those patients will have their first hospitalized infection or serious infection within 3 to 4 years. So now we go to the risk of potentially contracting the virus and having COVID-19. A recently published UK study has shown that even though we were considering that MS patients are at greater risk, patients who were taking immunomodulator therapy do not have significantly different risk of acquiring or contracting the virus when compared to the general British population. The only demographic difference that was higher, significantly associated with contracting the virus, was being part of the Black, Asian, or other ethnic minority in UK when compared to the white MS patients. And this is to no surprise, given that we know here in US as well that the African American and Latin communities are the most affected population that are contracting and having the most serious outcomes with COVID-19. Finally, a study from Italy has shown that having this internal knowledge that MS patients are at greater risk for infections, MS patients have utilized greater protective practices in terms of greater lockdown score, which drives the lower rate of COVID-19 in MS patients in Italy and worldwide. Furthermore, an Austrian database has tried to understand how many of our MS patients are at potentially greater risk for severe COVID-19. And they analyzed their almost 2,500 MS patients using a modified version of a scoring system that understands the risk of a certain patient in terms of having COVID-19. And as you can see in the first table, factors like diabetes, age, chronic kidney disease, chronic obstructive pulmonary disease are scored towards having greater risk of having more severe COVID-19 disease. And based on their analysis, they have shown that very small percentage of our MS patients are actually fit within this high risk of population to have severe COVID-19 disease. Approximately 9% of them were like that. And what is more importantly is that out of these 9% of MS patients, only one was treated with a disease-modifying therapy, and none of these patients treated with a highly immunosuppressive immunomodulatory therapy. So going into the analysis of MS patients and their outcomes, this is the first pandemic in 100 years that our healthcare systems have been faced, and we learn by going with the disease and how do we deal with it. And luckily, the MS communities all around the world has been very organized in trying to scrutinize data that's coming very quickly about this disease. For example, the Italian registry was the first one to come online and collect data from Italy about MS patients that have contracted, and they're tracking the outcome of their COVID-19. And later, multiple societies like the North American Registry and 14 others around the world have started collecting that data. Finally, the Multiple Sclerosis International Federation and the Multiple Sclerosis Data Alliance have joined together with all these registries to create one global data sharing initiative where all data will be stored in one place and can be analyzed together for more reliable data analysis. And for that, I'm going to present studies from the Italian registry, from the North American registry, and from the Global Data Sharing Initiative. So to start off, Italy is where the virus hit the most at the beginning, and then it spread later on into different diseases. So we're going to start with the Italian experience of COVID-19 and MS. From January 15th to May 31st, Italy has recorded 784 MS patients with a suspected COVID-19 disease, of which only 25% of them were confirmed using PCR testing, as I mentioned. Out of these 192 PCR positive COVID-19 MS patients, 12 of them had additional one more patient had died out of these patients who had symptoms, but they had negative tests. And when we compare this ratio of 192 to 12, the mortality ratio, to the Italian-wide lethality rate, MS patients had a double mortality odds ratio. So in a general Italian population, if 192 patients got COVID-19, we expect to have 6 of them dying, whereas we had 12 MS patients do so. And when we look at compare this COVID-19 MS population with the general Italian MS population, we can see that these patients were more commonly treated with medications like ocrelizumab and natalizumab, and less commonly treated with interferon beta and glatiramal acetate, potentially suggesting to some disease-modifying treatment effect in contracting and having severe outcomes in multiple sclerosis patients. Furthermore, they looked at different factors that are associated with severe outcomes, and as severe outcomes with COVID-19 are considered either being hospitalized in the ICU, having radiologically documented pneumonia, or being generally hospitalized in a hospital. And so we can see that 15.7% of our MS patients had such severe COVID-19 disease. Factors associated with having severe COVID-19 disease or being hospitalized were older age, male sex, having higher disability, longer MS duration, having progressive type of multiple sclerosis, and as with the common general population, having presence of comorbidities. Furthermore, when compared to dimethyl fumarate as a baseline for comparison, the data show that patients who were treated with specifically anti-CD20 therapy and were not treated at all were at a greater risk of having severe outcomes of COVID-19. Lastly, and interestingly, they showed that patients who had received intravenous steroid treatment within 1 month before the symptom onset of COVID-19 were also associated with increased risk to have severe COVID-19 outcome. Now we're going to look at the French experience and their data, and from the period from 1st of March to May 21st, 347 MS patients were registered as having both MS and COVID-19. And as we saw with the Italian experience, here it was replicated with the French experience as well. patients who were treated with more potent medications like natalizumab, ocrelizumab, rituximab had significantly more severe outcomes with COVID-19 compared to other medications. And lastly, patients who were not treated at all had also had a lot more severe COVID-19 outcome compared to the other medication. And there's an explanation that I'm going to touch upon a little bit later. Similarly, with the Italian group, the French showed the same results, showing that age, male sex, obesity, cardiac comorbidity, and higher disability levels were associated with more severe COVID-19. Look at the North American experience, and this is the COVIM's registry that I mentioned originally. Up until this weekend, we had 1,251 registered patients with COVID-19 and a demyelinating disease of majority, 95% was confirmed multiple sclerosis. Out of this patients, we have 58 deaths occurring, or 4.4%, and this occurred in 54 MS patients and 4 neuromyelitis disease. In terms of the North American experience, factors associated with the most severe outcome that there is with COVID-19 death was having a progressive type of disease, being severely disabled or non-ambulatory, has cardiovascular or other comorbidities like obesity and hypertension. And as we mentioned previously, these patients were not treated compared to the others. This is just analysis from during this weekend that I did. It's not a formal analysis of the data. And lastly, data from the Global Data Sharing Initiative has definitely confirmed all the previous experiences in national registries as well. So we had more than 1,500 patients with suspected COVID-19, and out of those, 313 were admitted at the hospital, 76 had ICU admission, 54 were put on ventilators, and 48 deaths occurred. And like the previous experiences, being older, having progressive disease, being more disabled was associated with more likely to be to a hospital or ICU. And most importantly, they showed that anti-CD20 therapy, that being ocrelizumab and rituximab, particularly rituximab, was associated with more severe outcomes in this particular case with hospital admissions compared to the dimethyl fumarate, which was considered as baseline. Similarly, the trend of having no treatment was associated with also worse clinical outcomes and hospitalization. So to summarize this part of the talk, multiple national registries and a global initiative are actively collecting comprehensive data regarding COVID-19 risk and their outcomes in multiple sclerosis patients. Comparably to the general population, older age, presence of comorbidities, progressive type of MS, and greater disability were all associated with worse COVID-19 outcome. Furthermore, presence or treatment with anti-CD20 medications, particularly rituximab, and non-treated MS patients were potentially at a greater risk for worse COVID-19 outcome. When it mentioned non-treated MS patients, usually our patients who are most severely disabled and have progressive disease, we do not have such a plethora of medications for those treatments as we have for our less disabled and younger patients. Therefore, it's more commonly that a progressive patient would be the one that is not being treated. And that's the link between non-treated MS patients and having progressive disease. Finally, 2 independent studies have shown that the total amount of lymphocyte count in the MS patients was not associated with the worst COVID-19 outcome. So going forward, multiple sclerosis societies came out with national and international guidelines. How do we treat and monitor MS patients during the COVID-19 pandemic? We have the European Academy of Neurology, the American Academy of Neurology, the British Consortium, and the Francophone, the French, came with their own guidelines. Furthermore, we have thought leaders and opinion makers in the multiple sclerosis field that have published papers in high impact factor journals like Annals of Neurology, Neurology, and MSJ. And surprisingly, all these 14 different guidelines that came out in the recent few months have the same theme within them. Usually the guidelines suggest that newly diagnosed MS patients should start treatment with interferons, clotrimazole acetate, or natalizumab. and to avoid treatments like the anti-CD20 monoclonal antibodies and other immunosuppressive therapies like the alemtuzumab and cladribine. All guidelines suggest that existing MS patients to continue current disease-modifying therapy and potentially consider a delay of certain treatments like the anti-CD20 medications. Furthermore, patients with already having active COVID-19 should hold off all medications except potential interferon beta, which we know is being independently tested in the general population as potential treatment for COVID-19. Lastly, neurologists should consider having higher threshold after acute relapse to prescribe intravenous steroids. We know that intravenous steroids make the recovery faster from the relapse, but not a lot of data shows that having intravenous steroids necessarily improve the outcome of the recovery in that relapse. And here's a table showing the differences of which guidelines suggest increased risk or no increased risk of having specific MS medication. So going forward into vaccination, which is definitely the topic everywhere in the world, MS patients have specific guidelines how to follow vaccination during their disease and their treatment. Generally, MS patients are recommended against using live attenuated vaccines, and a great proportion of COVID-19 vaccines will be live attenuated vaccines. And MS patients are always suggested to discontinue their DMT or receive their vaccine during stable disease, during their treatment. Here, for example, this is independent of COVID-19. Patients are suggested to have vaccinations approximately 6 weeks and sometimes 6 months before starting a medication or after discontinuing medication. Furthermore, being on such an immunosuppressive therapy, MS patients may be at risk of not responding sufficiently and building up an immune response to the vaccine itself and having defense to COVID-19. In general, patients who are treated only with interferon beta have equally or even better response to vaccination. And here I'm using influenza immunization as a comparable expectation from COVID-19 vaccination. All other medications like fingolimod, natalizumab, ocrelizumab, and rituximab significantly impair the effectiveness of vaccines in MS patients that are being treated with such medications. Furthermore, patients who will acquire COVID-19 successfully go through the disease, we have seen that these patients, because they're so immunosuppressed, even though they had the disease, they have not developed an immune system after the disease has passed, and they're at risk of contracting the disease again, especially in patients who are treated with ocrelizumab, cladribine, or rituximab. So therefore, we have to have some considerations. How do we go forward in this period of having COVID-19 vaccine in the near future? For example, a study has suggested that by extending the period between rituximab or ocrelizumab doses does not necessarily affect the annualized relapse rate or the amount of relapses that MS patients will have during that period of drug-free prolonged period. Furthermore, potential bridging with interferon beta during the washout period before vaccination may be helpful in these MS patients. And as I said before, interferon beta may enhance the responsiveness to vaccination, particularly to COVID-19. Just a short update on the current status of COVID-19 vaccines or SARS-CoV vaccines. We have currently 5 approved vaccines with limited use, of which 2 are in China, 2 are in Russia, and 1 is in the United Arab Emirates, of which most of these vaccines are those live attenuated vaccines. They cannot be used in MS patients or is suggested against use in MS patients. In phase 3 trial, we recently heard some news about vaccines who are developed by companies like Moderna and Pfizer and Johnson & Johnson, of which they have specific mRNA based of vaccination, which can be used in MS patients. And for that, we're going to discuss further a little bit later. For example, the Murdoch Children Research Institute is developing and currently in phase 3 trial, a BCG vaccine that also is known that potentially can improve MS outcomes independently of COVID-19. And to summarize my last part of the talk, both MS patients and their neurology providers should follow general country-based and MS-based guidelines in order to minimize the risk of infection and severe COVID-19 outcomes. Treated MS patients, with exception to interferon beta, have lower infection and vaccine humoral response compared to the general population. And providers and MS patients should carefully plan sometimes 6 to 9 months ahead when they're planning to delay their disease-modifying therapy for having the COVID-19 vaccination. And finally, MS patients are suggested to avoid live and live-attenuated vaccines, and vaccination with mRNA or viral protein-based vaccines is recommended. Thank you very much for listening.
Okay, thank you, Dejan. And now let me introduce Professor Clerici, who will discuss the lecture and will open the Q&A section. I invite the attendees to write the questions in the chat so they can answer after Professor Clerici will discuss the question, and he will do his questions. So Mario Clerici is full professor of immunology and head of the Department of Physiopathology and Transplantation at the University of Milan. He is also the scientific director of the Scientific Institute Don Gnocchi Foundation in Milan. His research interests include innovative research in the immunopathology of human diseases and evolutionary genetics in multiple sclerosis, autistic spectrum disorder children, and Alzheimer's disease. As the head of the Department of Molecular Medicine and of the MRI laboratory, he promotes multimodal studies using genetics, immunology, rehabilitation, and advanced neuroimaging techniques. He has authored more than 650 papers, being one of the most cited scientists worldwide. Thank you, Marco. So you can start.
Grazie, Marcella, thank you. And thank you, Dejan. That was a fantastic overview of what's excellent job. I would like to start out with like two considerations. The first one, MS patients behave like the general population. COVID is killing elderly patients that have a more compromised general status and a more severe disease. So like what's going on with COVID in MS patients, it's pretty much like what's going on in the population at large. The second observation is that it stems from the fact that interferon beta treated patients are doing better. That makes sense because, as you know, interferon beta has a very strong antiviral effect. So it makes sense as SARS-CoV-2, it's a virus. So if we give interferon beta to patients, like antiviral defenses should work better. Of course, like the topic of the day is the vaccine, because as you know, the Pfizer data seems to suggest that we are very close to having an effective vaccine. Which is, in my opinion, the only way to stop this pandemics. This pandemics will not be stopped unless we will be able to vaccinate. What's a vaccine and how do we build it? Just very briefly, you need an antigen, which is like, it used to be a protein, and you need an adjuvant. The antigen is the one that gives the specificity to the vaccine. The adjuvant is the one that confers the magnitude and the duration of the response. In the next slide, we'll show you in a graphical way the effect of the antigen and the adjuvant. So essentially, the antigen says how precise the arrow will be. The adjuvant will tell you how strong the arrow will be thrown at the target. Life is much more complex than that, because it used to be that we were making vaccines with a protein. Now, as you see, the antigen is I mean, we have multiple types. So like picking the right antigen, it's not an easy task. And in the next slide, you will see that also picking the right adjuvant, it's a total mess. It's not easy. So how are the vaccines that are working for coronavirus made? It's from an immunological point of view, this is a fantastic advance. We have been trying the concept of like building a vaccine using RNA of virus comes from HIV research. It never worked with HIV because HIV changes so fast that it's impossible to induce an immune response. But it works very well with coronavirus, which is like a virus that doesn't change. So like both the Moderna and the Pfizer vaccines, which are the ones that are very close to being brought to the market, are developed using RNA that codifies proteins for the spike protein. If you consider it's a fantastic idea, because we go from injecting proteins to injecting into human cells the instructions on how to make proteins. It's it's like mind-boggling. It's a fantastic thing. Does this work? Yes, it does work. Like these data show the generation of neutralizing antibodies directed toward the spike protein, and the next slide shows you the generation of Th1 cells. So like this is a vaccine, both the Moderna and the Pfizer vaccines are able to elicit the best of both worlds, antibodies and T cells. The problem is that like as in every immunocompromised host, it might not be very wise to use an RNA-based vaccine. Problem is that these two are the vaccines that like we get on the in the clinical scenario very soon. Of course, when they will get there, I'm not sure that like the other vaccines which are based on a more traditional formulation will get to the market. So like the conundrum will be like, will be willing to vaccinate MS patients with vaccines that potentially might damage them, or is it best to risk the fact that they get COVID and they might have clinical problems stemming from the COVID from SARS-CoV-2 virus? I don't know. That's the question. That's the problems that are on the table. Marcella, I've done my job now. Like, back to you.
And I have to say, I'm sorry, Dr. Lagana, I have to say that the road to discovery of interferon beta as a treatment for multiple sclerosis had a viral hypothesis in mind. In the 1960s and the 1970s, they thought that multiple sclerosis is being caused by a virus, and this is still a prevalent hypothesis in the MS field. And that's why initially patients were injected with interferon gamma and then interferon beta, thinking that this is going to be an antiviral property of the medication, which worked, but even though we still don't know if it's true or not, if it's a viral hypothesis or not. So yes, I agree.
You're totally correct. Thank you for this comment. This was very wise because it gave it a historical perspective. Thank you.
So, Professor Clerici, do you want to start with the questions?
Yes.
For Diana, or otherwise I can start. And
start with the questions, sure, yes. There's a question that I see about vitamin D. I mean, Marcella, you know that we did like some studies, not so much on vitamin D, but on the vitamin D receptor. So, the vitamin D receptor is includes a series of SNPs of single nucleotide polymorphisms that determine the efficacy with which like the binding of vitamin D to the VDR will activate cells. There are data showing that in MS patients, some SNPs that suppress or diminish the action of the vitamin D receptor are prevalent. So, you know, it might be, I mean, it's not gonna hold for sure to increase, to supplement the diet with vitamin D. It's not gonna be the cure, but it's not, I don't think it's gonna damage patients.
To answer Dr. Beck's question, all MS patients, irrelevantly of COVID-19 pandemic, were treated with 4,000 to 6,000 units of international units of vitamin D, knowingly that vitamin D has potential effect in multiple sclerosis relapse rate outside of the COVID-19. So in that way, our MS patients are already using the recommendations of having these 2,000 to 3,000 international units of vitamin D that has been mentioned as potentially adjuvant thing that general population can do for protecting themselves of COVID-19.
Exactly, yes.
Hi, Dan. This is Dr. Zivadenov. Excellent presentation, really compliments for that. I would like to ask you a little bit about the results on non-treated patients, because on one hand, non-treated patients may be not treated because they were in advanced phase of the disease, but we also know that at least 15 to 20% of the patients who are not in advanced phase of the disease are not treated. Do you have any data about these non-treated patients in various registries, at which stage of the disease they were? And in relation to that, I think that particularly it's interesting to examine the cytokine storm effects in these non-treated patients, because they may have much more severe cytokine storm than patients who are treated with DNTs, from what we know now based on the research with the DNTs in MS.
Those 2 points are very valid and excellent comments. Unfortunately, the North American registry, which I have access to, has not necessarily separated which patients were the non-treated, are they secondary progressive type of patients or relapse remitting MS patients. I'm sure at the back end, the Italian registry has this data, and I think that currently their paper is being in medRxiv, and I think it's being submitted for publication. So potentially they can answer that data. However, the data that I presented is heavily influenced that the majority of the non-treated MS patients are those who have primary progressive MS, secondary progressive MS, and they're non-ambulatory. They have a lot of comorbidities, and usually they go hand in hand. And lastly, is patients who are significantly older. There is this divide in the MS community right now that we say that the current disease-modifying therapies do not have an efficacy or do not have an effect after a certain age in our MS patients. Is that over 60 years old, over 70 years old? So a lot of clinics tend to discontinue patients out of therapy after they continue their threshold of 60 to 70 years old. So this is also another confounding factor of age, progressive disease, and not having disease-modifying therapy, which all lead to severe COVID-19 outcome.
And to follow up just with another very brief question to Professor Clerici, based on the list of different types of vaccines in terms of their origin, how they are developed, what do you think would be the best case scenario for MS patients? Which type of those vaccines that you showed?
Thank you. Well, I mean, for sure, the best case scenario for MS patients and for all type of immunodepressed patients. I'm thinking, you know, because I come from HIV research, I think of like HIV patients, which are, you know, tens of millions. Protein plus adjuvant or whole kill the virus. You want to have something that does not replicate in the host. that would be the best scenario.
I have a question for Dr. Jakimowski.
Hi, Deanne. Yes, I have a question. So can you comment on any specific brain imaging findings on MRI in MS patients who have COVID-19? Because do you have any people published the data show any specific signs we can use to differentiate MS lesions from the COVID-related lesions? Probably there are not enough data because you didn't.
Unfortunately, there are only case reports and case series of MS patients that are undergo both COVID-19 disease and they're being scanned. There are several reports showing that COVID-19 has associated with some cortical lesions, and I'm sure we're going to hear a lot more in the second talk about types of lesions that COVID-19 are associated with in the brain. But unfortunately, these are old registers of either self-reported data to a registry, or the provider goes to the registry and inputs the data, where this is not on-hand experience examining COVID-19 MS patients in each clinic. And I think that we're going to have opportunity of knowing a little bit more about COVID-19 outcomes. This season of COVID-19 will give us more opportunity to try to study the MRI in MS patients with COVID-19.
Okay, thank you.
Diane, you have any data about natalizumab or ocrelizumab and the coagulation? Because usually COVID-19, the severity of the disease is due to thrombotic and thromboembolic complication. There is an unexplained hypercoagulability status. So I would like to know if the drugs that are related to the more worsened, to the more bad outcomes may have some prothrombotic potentiality.
Based on the clinical phase 3 trials of both ocrelizumab and all the wealth of data we have on natalizumab, they do not come up as side effects. They have come up as side effects in the past 10 or 5 years in terms of treatment. We all know that treatment with ocrelizumab and rituximab is associated with significant outbreak of herpes virus infection, hospitalized because of herpes zoster, and also a lot of upper respiratory tract infections. Nasopharyngitis is the most common side effect of being treated with ocrelizumab and rituximab. So this falls in line of having the susceptibility to a viral type of disease with a cytokine type of reaction, rather than the thromboembolic type of interference with the disease-modifying therapies.
Okay, wonderful. Dejan, thank you very much. We have a question from the audience. Can I read it for you?
Of course.
Okay, so Ludmila Beleyev. What about vitamin C, D3, selenium, and zinc for prophylactic of COVID-19? I think in MS patients or in general, what do you think about?
So as we mentioned, the vitamin D or vitamin D3, the activated form of vitamin D, is being routinely prescribed to all MS patients based on the 20 years of data that we have. Usually MS patients in our clinics are being prescribed 4,000 to 5,000 international units per day, or sometimes they're being prescribed 50,000 units weekly. And this is a dose maybe potentially on the high end for the general population. What I've seen suggestions of the general population as a prophylaxis for COVID-19 ranges between 1,000 to 2,000 international units of vitamin D3 as potentially prophylactic effect. In terms of vitamin C, selenium, and zinc, there's no specific data about their effect in multiple sclerosis in as patients, and I am not aware of any studies that try to understand the differences in COVID-19 outcomes between patients who are taking supplements of vitamin C, zinc, and selenium versus the outcomes in general population who is not having this supplementation.
Thank you very much, Dejan. Marcella, have you?
Okay, yeah, I think that if there are not other questions, I have one.
Okay.
So I want to ask you, Dejan, if can vaccine worsen MS, and if so, which are the pros in doing the flu vaccine this year?
Mm-hmm. So the flu vaccination, influenza vaccination has been a debate in the MS community for 20 years or so, for apparently not scientific data. In general, I'm going to refer to a study published almost 25 years ago. In 1997, in neurology, there was a clinical trial where they vaccinated patients with the yearly influenza vaccine, and they did not show that the annualized relapse rate in the vaccinated versus non-vaccinated MS patients was different. So the influenza vaccination did not cause more relapses, as a lot of people have suggested otherwise. Furthermore, interestingly, the data showed that patients who were vaccinated for influenza, their time to relapse was longer than patients who were not vaccinated for influenza. And this can also be explained by the fact that if you do get to contract the flu virus, if you contract influenza, the increase in temperature, the increase in having the disease is a greater risk factor of inducing an MS relapse than just having potentially any side effects from having the vaccine of influenza.
Okay. Wonderful, thank you. So I think that now Erika can introduce the next talk.
Okay, so we can go to the next speaker, and it is my pleasure to introduce Dr. Nivedita Agarwal. She is a neurologist and a consultant in neuroradiology, actually working in the Department of Radiology of Rovereto Hospital in Italy. And she is also medical director of a functional neuroimaging laboratory at the University of Trento. Research cooperation with international university, in particularly in the United States and in the UK. Dr. Agarwal actively serves on the board of the International Society of Magnetic Resonance in Medicine. And she is also a member of our society. And she will talk about the several phases of COVID-19 and brain lesion, the usual and the unusual, giving us a new data regarding many different ways to SARS-CoV may affect the central and peripheral nervous system. So Nivedita, the podium is yours.
Thank you so much for the kind invitation, Erika and Marcella and Yulin. What I'm going to do today is to give you an update of the kind of brain lesions that have been reported so far in the literature, starting from about April, May to this month. By first analyzing, can you see my screen? No, nobody can see my screen. Hold on, let me share my screen first. Okay. Sorry, so that is not what you want to see. What you want to see is this one here. All right, can you see my screen?
Yes.
Okay. All right, so what I want to do today with you is to illustrate our first published case. This was in early May, and we were in the acute phase of the pandemic in Italy. And we had just started doing a brain MRI, which was not the the first modality of imaging patients with some kind of neurological deficit. People were just going for CT of the brain. So I'm going to illustrate that and how that would started off a thinking process amongst the neurologists, what the virus potential for neurotropism, neuroinflammation, and neuroinvasion is. Finally showing you the various kind of brain MRI lesions that have been reported so far, suggesting different pathophysiologic mechanisms by which the virus can actually affect the brain and spine. Before we start, this is where we were when I saw my first MR case. We had about 10 results and nothing really, not a lot on brain MRI so far, but yes, just kind of 10 publications. By the end of this last month, we have about 162 cases that have been reported, and that COVID-19 or SARS-CoV-2 does affect the brain. We know this for a fact just by the sheer number of publications that have been reported so far. It's about 2,000 publications in all different kinds of languages. This is where we are. The SARS-CoV-2 is a coronavirus. You guys, everybody knows about this. And I kind of keep saying that every person on the planet knows about SARS-CoV-2, beta coronaviruses, and that they are a really heavy RNA-based viruses. There are geneticists who are working on it and on this virus, and they say that the virus does have ability to recombine, mutate, and infect a number of animals, and novel strains of coronaviruses continue to evolve, emerge, and cause new outbreaks. All right, so this is our case, right? So this is the 17th of April. We have a 71-year-old male which comes up to the ER with severe respiratory symptoms. He actually came after 1 week of having these symptoms. By the time he could not breathe properly and saturate enough, he was in the hospital, and we had a CT of the lung. I don't have to explain these results anymore to anyone. We all are aware of how they look. And we also did a brain CT because of its neurological complications, which basically were altered consciousness. We did see this little lesion in the spine of the corpus callosum, and we're not sure whether to report it, whether it was a lesion or not. So we decided to do a brain MRI, and this is what we saw. What we see is a lesion in the splenium of the corpus callosum. For neuroradiologists and radiologists who are listening to us today, you can clearly see this little hyperintense lesion on T1 weighted images. There is some blooming on the GRE. There is no enhancement on the contrast enhanced imaging. I did do this also to figure out some kind of thrombosis, or could this be a sign of stroke? And you have to you just have to scan rapidly because these patients are very unstable, and you just keep them in the car for just the time that is required to get this kind of data out. Looking at this case without having much about what was going on in these patients back then, we looked into the literature and we're like, okay, so lesions of the spine of the corpus callosum, first thing we think about is a demyelinating lesion, right? After that, these lesions could also be a toxic lesion because of different kinds of pathologies, alcoholic encephalopathy, vitamin deficiency, etc. It could be a stroke, very, very rare to have splenium artery stroke with hemorrhagic formation. And then we have a whole host of cytotoxic lesions that we are very well aware of. And that could be either due to drugs, anti-epileptics, sedatives, and even other kinds of treatment. And it could also be virus. So for example, influenza virus is one of those viruses that can, and especially in kids, give these kind of transitory reversible cytotoxic lesions of the corpus callosum. And since there was hemorrhage in this lesion in our patient, we thought that this could fit into a hemorrhaged cytotoxic lesion of the corpus callosum because of anticoagulants that the patient was receiving. Now, how do we make this diagnosis? Basically, you go in to do a lumbar puncture, figure out if there are any kind of, oligochronal bands, there's something else going on. Everything was negative, and we decided that this was a cytotoxic lesion of the corpus callosum. But again, it's not definitive that this was virus, virus entering into the brain that caused the lesion. It could be a host of, there could be different reasons because we saw this lesion. It could be due to drugs, it could be because of the infection itself, it could be a stroke, etc. Now, again, we know what the cytokine storm is. It is absolutely not new to COVID-19. Cytokine storm is it's an exaggerated response to an infection. And what happens in the brain is that there is a severe large activation of microglia that produce a lot of cytokines and then can disrupt and actually cause what we call neuroinflammation. and this is actually an image that I really like, and this was in 2017 in the pre-COVID era, where the brain is on fire when there is a cytokine storm. So there is basically what we call neuroinflammation. And neuroinflammation, the only way probably we can pick up in brain imaging is by doing PET-MRI. There is this interesting case series of 4 patients with was studied with FDG PET, where they found that there were areas of hypometabolism in several areas of the patients with COVID-19, especially in the orbitofrontal areas and the cerebellum. There are different kinds of viruses, right? We all know about this. And viruses, they attack the peripheral body tissue. And they don't have any advantage in attacking brain or even the spine, because once the human body, once the brain is affected, you really have a very, very damaging response. And it could really be more deadly. And if it's deadly, then the virus will die as well. So usually the brain will respond very well, but once the defenses, they fail, then the inflammation becomes so strong that it causes this kind of viral neuroinflammation. So even though there are certain viruses that attack the brain directly, most of them actually remain with us, for example, the JC virus or even the herpes virus. Very quickly, what the coronavirus does, again, is these S proteins that attach to ACE2 receptors, and they get inside the cell and then start to replicate, causing mostly apoptosis of the cell. And the way this can happen is either through the peripheral nerve or the cranial nerves, and we'll see that in just a moment. Now, ACE receptors, actually 2020 is the 20th anniversary of its discovery, and ACE2 has now become the receptor through which SARS-CoV-2 interacts with most cells in the body. Again, many different areas, many different organs, pretty much all of them have ACE2 receptors. And in the central nervous system, most of them are found in the circumventricular organs. And again, just an image to show you where these organs are. These are usually organs that are devoid of blood-brain barrier. They are flushed with blood because these are chemotors. They check the level of oxygen, they check the level of sodium, hydration, and communicate with the lungs and the heart to adjust, and also a lot of other organs, such as the adrenal glands, to maintain a certain level of homeostasis. So what is neurotropism and neuroinvasion, at least when it comes to viruses in general? Now, you could have a hematopoietic spread. So ACE2 receptors are on the endothelial cells, and what happens is they can enter through the endothelial cells and start a prothrombotic reaction, or even cause hemorrhage of these vessels. Virus could potentially enter the CSF through choroid plexi. The other way would be the retroinvasion of the CNS, either through via cranial nerves or via the peripheral nervous system. Again, this is something we all know, in the sense that COVID-19 supposedly gives a large amount of people do have symptoms like anosmia or hyposmia, or even loss of taste. And this is just a little figure that will show you where the olfactory bulb is, the nerve endings that are within the sinus and nasal cavity, and virus can theoretically pass through these nerves, enter the olfactory bulb, and reach the brain areas that it is directly connected to. This is again another cartoon just so you guys can see, there are different type of cranial nerves through which virus can enter the brain. The same is true with the peripheral nervous system, really. Again, retrograde or anterograde, through the axons that virus can enter and reach the spinal cord or the brain. This is nothing specific to SARS-CoV-2. This is something we know from our own understanding of other viruses like herpes virus. an image to show you. You can actually see these olfactory bulbs. These are little nerve endings through the cribriform plate. These are the two olfactory bulbs. This is the nose, so virus can easily enter the brain through these little openings through this cribriform plate. This is one of the first major case report where the authors suggested that these areas where there are these lesions called acute necrotizing encephalopathy, these lesions were actually in the areas of areas that were directly or indirectly connected to the olfactory bulb. So you can see the medial temporal lobes and the thalami, and so there was probably a progression in progressive invasion of the nerves through the olfactory bulbs into the brain areas of interest. This is another case. Again, you can see these lesions in the areas of the olfactory bulb. This is the hyperintensity in the olfactory bulbs. Again, suggesting that this was one of the routes of entry of the virus into the brain. Now, neurological manifestations, there are a lot of reports. This is one of them. I think this was published in July. So several, again, cohorts, the Chinese, the Spanish, the Italians, Americans, they have reported every kind of neurological symptom and manifestations, and the variability is about from 17 to 57% of patients will have some kind of neurological manifestation, going from central nervous system manifestations, peripheral nervous system manifestations, also to things like myalgias. When it comes to brain MRI, about 50%, 47% seem to have some kind of acute neuroimaging abnormalities. And as you go through the list, you will realize that really nothing specific related to COVID-19 is being reported. There might be an increased incidence of these lesions in patients who are COVID positive. But again, we as neuroradiologists are aware that we can see stroke in these patients and other findings as well. This is a very interesting, beautiful paper by a French group, Stephanie Kremer, and they have reported at least these 8 different patterns of brain MRI abnormalities. I will show you some of them. So you have unilateral lesions. You could have, again, a lesion in the spleen of the corpus callosum. You could have non-confluent white matter hyperintensities, unilateral, bilateral, or even cerebellar lesions. This is an SWI image. What you can see are little petechial hemorrhages that are basically pretty much in the entire brain, infratentorial and supratentorial. This is a case we heard earlier, Dejan, responding to one of the questions regarding demyelinating lesions, whether we can separate them from, MS plaques. Again, it would be, we still don't have that kind of data, but remember, we have things like ADEM, the acute disseminated encephalomyelitis, where you can have these large demyelinating plaques, and again, pretty specific, and we know that these can actually happen in many other viral infections. This is another case that was reported where we have, it's called PRESS, posterior reversible encephalopathy syndrome. Again, you can see these lesions, another patient who was COVID positive, and these lesions can also hemorrhage. Again, is this something related to the anticoagulant therapy that these patients are doing? So this is drug related, or is it because of the cytokine storm, because of the hemorrhagic or alterations of the endothelium caused by virus? We really don't know that yet. This is by Ali Radmanesh, one of our panelists. He's done a few publications on this, and you can see lesions bilaterally in the cerebellar peduncles, and frankly, you can see these lesions. Some similar kind of lesions, even with multiple sclerosis. This is a very recent report, trying to find out if there is a long-term, what happens long-term to these lesions. And as you can see in this patient, day 10, you can see some of these diffusion-restricted lesions in the corpus, centrum semiovale in the deep white matter, which progressed into necrotizing leukoencephalopathy. And really very clever. They call it virus-associated disseminated necrotic acute leukoencephalopathy, saying that this is something specific to these patients, to this virus. This is a statement that I actually hijacked myself from a neurologist, Jason Hinman. He says COVID-19 hijacks brain blood vessels. I bring this up separately also in honor of the society we are that is hosting this webinar, which is very much focused on vessels, whether they're arteries or veins, to understand what is going on in the brain in several diseases. So what do we know about COVID-19 or SARS-CoV-2 and vessels? Now, if this is a study on pangolins, one of the animals that probably are the major reservoir, together with bats, of coronaviruses. And what you can see here is it's a lung biopsy, and you can see this is a normal lung, right? This is an influenza pulmonitis, and this is SARS-CoV-2, where you can see large amount of blood. This is just hemorrhagic. There's just a lot of blood in the lung tissue of patients infected with SARS-CoV-2. If we look into the tissue distribution of ACE2, ACE2 is really mostly in the endothelial cells, and that might explain why, you know, vessels are so, they are involved in this disease. This is, I think, the only neuropathology patient, large study of autopsy done on brain MRI patients who died of COVID-19 in different parts, whether in the hospital, nursing home, or at home. And they found, I'm going to read this out because I thought that this is really important. The brains of patients who died from COVID-19 are relatively mild. The alterations are relatively mild, although the virus is able to gain access to the brain. And the neuropathological alterations are most likely to be immune-mediated, and there does not seem to be fulminant virus-induced encephalitis nor direct evidence for SARS-CoV-2 caused CNS damage. Now, mind you, many patients have, they do get a lumbar puncture, and they are screened for the viral antigens as well. There are, discordant messages that are coming out from the literature. Some find the antigens, some don't. So we still probably don't know the answer. There is this whole debate on the fact that many young people, middle-aged people, they're dying of stroke. So this became a big thing in the US, all the newspapers were talking about it. There does seem to be a 7.6-fold increase in the odds of stroke with COVID-19 in patients with influenza, and even young adults can actually, show up, have strokes. This is one of those cases in which there was a massive pulmonitis, thrombosis, and you could see thrombosis in the venous system, in the sinuses of the brain in this patient. This is a case of deep venous thrombosis, a very unusual presentation. Again, right now, as we are learning of this very, very new in hyperacute pandemic phase, everything is being reported. And this is, again, interesting. This is a patient who comes to it seems that he presented to the hospital with deep vein thrombosis and had pulmonitis as well. It was most likely because of the prothrombotic activity that SARS-CoV-2 initiates in the body. So cytokine storm-driven thrombotic complications have been reported. It could be thrombosis in the skin, coronary thrombosis, pulmonary embolism, and in stroke. We need to remember that thrombotic complications can also be treatment-driven. So many of these treatments, like the ECMO, is used when patients are, they're not saturating properly. They have a very important respiratory insufficiency. So these can increase procoagulant, prothrombotic complications. So we need to be aware of that as well. And then this is pretty much it. And then again, all kinds of drugs that patients are given. So we have a situation in which patients use a lot of different kinds of drugs, call it sedatives, anti-epileptics, anticoagulants, cortisone, antiviral agents, a lot of this big, huge of drugs. So these can also complicate brain lesions that we see. Last but not least, we need to remember that a lot of psychiatric and neuropsychiatric presentations are associated with these infections, and we should be aware of the fact that SARS-CoV-2 and COVID-19 will result in a large number of people with depression, anxiety, fatigue, PTSD, etc. And these are also, according to me, complications of the disease in terms of neurological complications of this disease. Thank you.
I muted. Nivedita, can you hear me? Okay, thank you very much. Okay, thank you very much for this wonderful lecture. And now I would like to introduce the expert discussant of this lecture, Dr. Alireza Radmanesh, who is an assistant professor of radiology and director of pediatric neuroradiology at New York University Grossman School of Medicine. And he is also active in the American Society of Neuroradiology. He will give up a sum up of what the take-home messages are following his expert opinion on the topic. Please, Dr. Radmanesh.
Thank you, Erica, for the introduction. And thanks, Dr. Agarwal, for a beautiful overview of some of the brain findings in patients with COVID-19. The truth of the matter is our understanding about COVID-19 and what it does to the brain has undergone a true evolution. And that evolution is still ongoing, as is what the virus is doing to our patients. When we started attending webinars and conferences and group discussions like this back in March and April, when it was the peak of pandemic in New York City, we all thought that it's something that we're going to deal with for 3 or 4 months and get over it. But here we are 9 months after that peak and worried about what smells like the second surge in New York City. So it looks like we're on this for quite some time, for at least several months longer. And I think not only that, but even when we look at this pandemic in the rear view mirror, we should actually look at it as disastrous as it is, and also an opportunity to be able to grasp a lot of understanding about a process like this. And maybe in our lifetime, hopefully this will be the last pandemic that we'll see, but I'm sure the lessons that we learn apply to the next pandemic that is definitely going to happen. So as Dr. Agarwal pointed out beautifully, so what we've seen in patients has really gone through a course of changes over time. So back in March and April, when we have the peak of COVID in New York City, most of the patients that came to our attention and the attention of our neurology colleagues were patients who were having stroke or intracranial hemorrhage. So it seemed like at the beginning, we were dealing with a host of macrovascular complications in patients with COVID-19. Gradually, as we were getting close to the post-peak era of the pandemic in the city, we started seeing what appeared to be a microvascular course of the disease. And we were seeing findings such as white matter, flare hyperintensities, mainly in the supratentorial area, and to a lesser extent, as Dr. Agarwal showed, in the brainstem. We were seeing some areas of microhemorrhages, and along that, we are also seeing some inflammatory and post-inflammatory changes, both in the brain and spine, be it in the form of PRES, ADEM-like processes, demyelinating processes, or even Guillain-Barré disease in some of the patients. So it appeared that we had a process that fit in one of the three categories, either microvascular injury or macrovascular injury, or an inflammatory process going on in the brain, inflammatory or post-inflammatory process. So the association between COVID and these brain MRI findings, I believe, is well established. And it started with a bunch of case series and case reports, and then it evolved into larger case series and what we have recently seen as systematic reviews and meta-analysis that are starting to come out. And I'm hoping that gradually we start to see more animal models, and we are ultimately at the mercy of neuropathology reports. And when more neuropathology data is going to come out, it's going to shed a lot more light into the true meaning of what has really been an observation so far. So the main question is, are the associations that we are seeing and we are describing and we are reading, are they really causal associations or they're only causal? And the differentiation between causal and causal relationship has been a struggle for years for different disease processes. And what epidemiologists have used oftentimes to determine whether an association is causal or causal is a set of criteria named Bradford-Hill criteria. It's essentially a set of 10 different criterion that they use, and the more number of criterion that they have, the more confident they are that the relationship is really causal rather than causal. So what are we talking about? For example, we're talking about strength of association. How strong is the association between the two elements? We're talking about how reproducible is the association, how plausible is the association, and do we see a biological gradient, meaning are the patients with more severe COVID-19, are they prone to more severe form of these associations or these conditions that we are observing? So these sets of criteria that I'm not going to exhaust you with, and you can actually look up Bradford-Hill criteria, and they're very understandable and intuitive. They're making us believe that there is really a causal relationship between some of these findings, especially as it relates to the vascular abnormalities that we see in the brain and COVID-19, especially because some of the associations are much stronger than the associations that we see with other similar viruses, such as influenza. And that makes us believe that there is probably a vascular involvement going on in the process of disease. It is still unclear whether it is direct invasion to the endothelium or it is involvement of the vessel by way of inflammation and involvement of the endothelial cells. And to be honest with you, we are still left with more questions than answers with COVID-19 and the disaster that is going on. But I think, as I pointed out earlier, as disastrous as it has been for everybody in the world, really, I think we should also look at it as an opportunity. And I think we should not let a disaster go to waste if we can actually take advantage of it and learn something for the next pandemic. So I think I'm gonna just take this opportunity and open it to the questions and answers with the panelists. And I'll give it back to Erica.
Okay, so I invite all the panelists like Dr. Eki and Dr. Gay to open the discussion with questions.
Thank you very much, and thank you both for your comments. Nivedita, I really have some general thoughts and comments to make. So one of the most important things here is you say there can be up to 50% evidence of neurological changes in MRI, and about 50% of that is related to thrombosis and microbleeds and vascular changes. So that's a pretty large cohort. And so some of the questions that come to mind are, where is this damage taking place? Just like we heard a moment ago from Dr. Radmanish, is this occurring in the endothelium? Is there an endothelial breakdown that then leads to microbleeds and possibly stroke, depending on where those microbleeds take place? You know, are they taking place thalamus, internal capsule? You know, corpus callosum, for example, has very small blood vessels, and yet you're still seeing damage there. The thalamus has large draining veins, but very small arteries. They all basically are come from the circle of Willis as, you know, arteries that are on the order of 1 to 200 microns in size, very similar to the cerebral arteries. So is this damage taking place mostly at the level of arterioles and venules, or slightly larger vessels like cerebral arteries, or is it taking place at the capillary level? You know, how can we tell? I think, again, as Dr. Radmanish says, it's really important for us to, be able to ascertain this, and, you know, can we do this with the type of technology we have today? And there's one other component of this that I would close with and say, you know, what are the long-term ramifications of this? Are we going to see, outside of those immediate acute severe cases, those other 25% of the people use vascular damage in, are they going to have strokes a year from now, 3 years from now, 5 years from now? Are they going to have neuropsychiatric problems? Are they going to develop dementia within the next 5 years? Because, you know, how severely damaged has this been? Remember that in cerebral amyloid angiopathy, in dementia, there's a slow breakdown of the endothelial system over time that leads to many, many microbleeds that take place. And although I don't know if, is it possible for me, Erica, to share screen for a moment?
Yes, I think so.
Okay. Let me just see if I can do that briefly, and see if you can.
Okay, perfect.
See if you can see this. Can you see my screen okay?
Yes.
Okay, so I want to just briefly show you, you know, what does MR normally show, similar to what Nivedita showed some examples. It can show you MRA, it can show you the SWI to show you small microbleeds, but using a contrast agent called pheromoxetol, you can actually start to image vessels now that are 50 to 100 microns in size. And you can see that these images look like cadaver brain images, see incredibly tiny vessels. And I want to close with this example. So this is in the area of the internal capsule, globus pallidus, and putamen. These are cadaver brain images, and these are in vivo images using pheromoxetol. And you can see most of these tiny vessels and the small bifurcations that are taking place at both the arterial and the venous levels. So the question here is, how severe is that damage on these people? Is it only what you saw bleeding, Nivedita, or is in fact there systemic endothelial damage throughout the brain? And is it possible for us to begin to investigate this? Sorry for that long set of comments, but now I pass it back to you.
Mark, thank you so much for those questions and comments. Actually, they're really, really important comments, and I think we are still struggling for the answers. Now, number one, the incidence of stroke has increased. Absolutely, this is true. We are seeing more and more arterial strokes, but there are cases of venous thrombosis as well. Just by looking at microbleeds, you know, as you suggested, especially the thalamic microbleeds, they are more venous with respect to cortical strokes, which are more arterial. These things have not yet been systematically reported, unless Ali has something to add on this. So this is one way to go forward, is to understand whether these are arterial strokes or whether these are venous strokes. This will also explain, more about the pathophysiologic mechanisms. At this point, we only know that the disease causes a state of a prothrombotic state. And a lot of people have pulmonary embolism, for example, right? So it is a systemic disease. And that can affect the brain as well. So that is one of the questions that's, I think, is still unanswered, and I don't think we still have, according to the Bradford Hill criteria, as an association. What I showed you about the 47–50% of brain MRI abnormalities, a large part is stroke, but we are also seeing other kinds of lesions. So demyelinating lesions, for example, is another big category, and they are in all different areas. It could be in the brainstem or in the cerebellum or even in the supratentorial area. I haven't seen or read a paper where some kind of association has been made. Stroke can also occur in patients who don't have a severe disease. Okay, and this could be either casual or it could not be. We don't know that yet. We do know from some autoptic studies, and this is going back to Ali's, association criteria, that the brainstem nuclei are involved in these patients, and even in animals. This was very early studies that were reported that brainstem nuclei do have the viral antigens, and that there is a viral neurotropism through the cranial nerves, especially through the olfactory nerve. Of course, we can't track down using the imaging the vagus nerve and the other cranial nerves like the glossopharyngeal, etc. You showed some beautiful images. It would be nice to be able to do fast imaging on these patients. As I said, these patients are usually very unstable clinically. And so we need an MR protocol, because MR really is our biggest and the only way to look at the brain. And so we need this kind of fast imaging to understand if, what is going on, and collect as much data as we can, venous anatomy, arterial anatomy, the white matter, gray matter, understand whether the strokes are in the cortex or they're in the white matter, things like that. So that is definitely something we neuroradiologists should be working on. You had another question, I can't remember. Did I answer your questions? Partly at least.
Well, I think you talked a lot about the acute conditions, but
right. Yes.
If they've had this for a long time, then they'll be more stable. We can take a little longer to do studies like the micropharomoxetol study and really examine what's happened to them a year later or 2 years later. I'm worried about how many people are going to show effects when you have tens of millions of people affected around the world. Even if 10% of those people have been affected this way, both young people and older people alike, how is this going to have long-term effects on them?
So there are some cases suggest 4 months after the infection, these patients still have some cognitive deficits. We don't have any kind of systematic review on this. There is this one study that I showed you on MRI where there was a progressing MRI lesions, and pretty aggressive lesion, cystic lesions, as you saw, it's bandal. We still don't know, and definitely one of the questions that we will have to start answering as soon as we are at least up to the 1 year mark, and I'm guessing more of these papers will come out early next year. I do want to say that dementia, absolutely, especially in the elderly, but a lot of psychiatric, neuropsychiatric symptoms. Those are being reported. Even COVID-19. What does it mean? It's a coronavirus-related disease, and it's not a SARS-CoV-2 is the name of the virus. So COVID-19 would also include people who are going to show signs of depression, anxiety, even if they are asymptomatic, because they have lost their loved one or they've lost a job and things like that. So yes, and that's also something that needs to be part of the long-term effects of this disease.
So Nivedita, just a final comment then. It would be very interesting if imaging could help differentiate these populations of neuropsychiatric effects versus those with, more obvious stroke effects, for example, or major bleeds in the thalamus. If there has been a vascular effect, in the brainstem and the locus ceruleus, for example, which is now affiliated in part with schizophrenia, are there parts of the brain that are more at risk for vascular damage that can be associated with, frontal white matter changes for attention and cognition, or for depression, for example? This really does offer, as Dr. Radmanush said, an opportunity for us to not only discover what's happening here, but really to understand the brain's involvement with the vasculature and how it can maybe in part explain some of these neuropsychiatric changes that are taking place.
I think one of the things that we can do is do perfusion studies as well to figure out if there are areas of hypoperfusion. So the PET study that I showed you, there was some, all the 4 patients, for example, had a typical pattern of hypometabolism. So for example, the orbitofrontal cortices and the cerebellum were hypometabolic in all the 4 patients. But it's just one case series. People have not been doing it. I think it was a PET CT or PET-MR, never mind. But these are the kind of studies that we'll have to do to figure out if there are areas of the brain that have been particularly damaged. And as you know, our routine clinical MRI, we're not probably able to see a vast number of lesions that probably are there, but we just can't see them. So we need fast imaging. We need neuropathological studies as well. What's actually going on, and people also, psychiatrists and psychologists that can look at and go through the battery of testing to figure out if there are some kind of cognitive damages as well. And probably even do serial imaging, some kind of protocol for follow-up MR imaging. Ali, do you have something to add to this? I'd be excited to listen to you.
Yeah, I agree with everything you said, Dr. Agarwal, and Dr. Haki also pointed out some extremely important points. There's a lot that we don't know about how the vessels are involved, but by way of some of the findings that we see, it appears that the blood-brain barrier is somehow disrupted in some of these patients. For example, when we talk about the microhemorrhages, the pattern and the distribution of microhemorrhages that we see is very similar to what we see in people who have climbed Mount Everest, or people who have had hypoxemia for other reasons, being in ICU and under mechanical ventilation for a few weeks. And it appears that, and we know from neuropathologic data that in those cases, in high altitude hypoxemia or hypoxemia due to other medical conditions, we have disruption of blood-brain barrier that has been shown in autopsy data. So whether or not this is related to the direct damage to the endothelium, whether or not it's a damage to the type 4 collagen that is in the basement membrane, like which portion of the blood-brain barrier is actually directly hit in the course of the disease, it's yet to be known. And we don't know that. And I'm really glad that the concept of the long-term consequences of COVID came up, because in New York City, we've already started to see some of those patients who actually got involved in February, March, and April and recovered, coming to outpatient neurology clinic with either some non-specific symptoms, be it headaches, vertigo, some of them with tinnitus after the disease that they didn't have before the COVID-19 disease, or some of them with some presentations of depression. So whether or not it's just a natural consequence of being sick with a deadly disease and then not knowing whether or not they can recover, and that leading to depression, or the disease actually doing something at the neurotransmitter level or locus coeruleus, as Dr. Hockey mentioned. It's yet to be known, but it opens a whole new era of studying the brain in these people who have recovered from COVID, especially because in the acute phase of the disease, because most of them have acute renal dysfunction, we cannot give contrast. The course of the MR has to be really shortened so that they're not in the magnet for too long period of time. But after recovery, we can actually do a more extensive study, yet, perfusion studying with or without contrast. Nowadays with ASL, of course, we can do without contrast. Or ferumoxytol, as Dr. Hockey showed some beautiful images of. But like I said, it's very important to actually put together a registry of patients who have recovered from COVID, and then start to study the type of long-term consequences that they may have.
Okay, thank you, Dr. Ramanesh, and thank you, Dean Vedita, for your opinion. And so we have a couple of questions that we please do very quick answer because we are a little bit on late. So from Dr. Carlo Ghisalberti, how could be draft a clinical protocol to assess neurovascular protective therapeutic effect of, for example, an experimental drug by brain imaging?
Oh Lord. Neurovascular protective and therapeutic effects. Well, I guess depends what we're looking for. We're looking for a perfusion improvement. Are we looking for, some kind of cerebrovascular reactivity that is changing, with CO2 changes in the blood? It depends what we're looking for. So I think a clinical protocol will be in relation to the exact question that we are asking. So that's all I can really think of. Ali, do you have any other? We need a basic, we need the SWIs, and we need the basic sequences, definitely, but the most important that I can think of is perfusion, really.
Yeah, I agree. It's a hard question to answer because it depends on what type of intervention you're talking about. Is it going to be used in the acute phase of the disease? Is it going to be used in the post-acute phase of the disease? As I just pointed out, as I just pointed out, in the acute phase of the disease, we're dealing with some patients who almost invariably have some degree of acute renal failure. And in those patients, obviously, we refrain from giving contrast. So then of non-contrast sequences such as diffusion, susceptibility, and for perfusion data, you can rely on ASL. And of course, in terms of the design of the study, then it's up to you whether or not you want to do some sort of before-after comparison or some sort of case control comparison. That pretty much depends on how you design your study. In the post-acute phase, your hands are a little more untied in terms of what you can use. You can even consider doing contrast studies, assuming that the patient's renal function has recovered, and then that opens a whole host of different perfusion options, susceptibility or contrast-based, to actually look at the blood-brain barrier and the effect on perfusion.
Yeah, you can actually, in the long term, you can even, go to the extent of wanting to do some kind of fMRI study, even resting state, to figure out if there are cognitive symptoms or cognitive deficits in these patients. So in the acute phase, it's really, really, yes, very limited.
Okay, maybe last question from the audience. Nivedita, what do you, maybe Dr. Sandra Birrell, that is asking what is neurovascular involvement in whole COVID-19, and in addition, how do these complications compare with EME and CFS?
What is ME and CFS? CFS, is it chronic fatigue syndrome? What are we talking about? And what is ME?
ME, I don't
Or
know.
is it some kind of typo? We're talking about MS. Ali, do you
Maybe.
understand
Maybe.
that? Yeah.
Maybe we can answer to the first part of the question, please.
Yeah, again, neurovascular involvement in long haul, we just don't have a lot of data right now. I think it's going to be very important to know if these patients are at a higher risk of getting a second or third stroke. Just because we don't know what's going on, how the brain is reacting, if the antigens are present, just for example, in patients with JC virus, right? I mean, they're already in the neurons, so we don't know in SARS-CoV-2 what's going on, in COVID-19 what's going on. You know, we know that they are at a higher risk of thrombosis, so I'm guessing that these patients have been taken care of at least from a drug therapy, and so they should not be at a higher risk. But it's just too early to answer these questions. Even though I understand that we are all wanting to know what's going to be in the chronic stage in the longer term.
Okay,
Just
so
to add up,
please.
sorry, Erica. So in terms of the chronic fatigue syndrome, maybe there is a differentiation between those patients who are prothrombotic versus those patients who have olfactory enhancement. And it does look like something like the herpes encephalopathy with medial temporal enhancement and olfactory nerve. And usually these patients in herpes encephalopathy are associated with increased risk for dementia, cognitive problems, and depression. So maybe there are a group of patients who have this transmission of the virus who enters through the olfactory nerve to the temporal lobe versus patients who are prothrombotic and have the blood-brain barrier problems going forward. So maybe the long-term aspect of these two groups might separate and differentiate going forward in terms of the risk for cognitive decline, fatigue, and potential dementia.
Awesome. Mm-hmm.
Yes, also thanks to both of you, the Niv and also Ali for the wonderful, the talk and the comments. I think it's almost 15 minutes passed. So yeah, I think still a lot of questions remained, and because it's a rapidly, emerging field still, a lot of unknowns. And I believe also the imaging findings you showed mainly from the kind of like the acute and the severe, the cases. A lot of probably not many studies on focusing on the mild, the patients who have just the symptoms like flu symptoms, what their effects on the brain. So you showed also the early sign, probably the olfactory bulb involvement. So what about the small vessels, the early signs? So we still don't know. Hopefully, we can have another, the webinar to follow up this, the questions. So the Marcella, do you want to wrap up with some comments and the future events?
Yes, thank you. So I will share just this slide. I just wanted to say that future webinars are coming next year. The first one, that is actually the fourth ISNVD webinar, regards approaches and applications for multi-contrast quantitative imaging, and it's planned on January. And the other one is regards neurofluids, physiology, methods, and diseases. The first webinar is managed by Dr. Reiki, and the second one is managed by Professor Toro of the University of Trento, and it will be on March. So if you are interested in these two teams, you can look at the website where we will put the dates and the program.
Okay, we thanks everyone, all the panelists and all the discussants and all the people who attend this third webinar. So see you next time.
Okay, thank you. Thank you all.
Thank you. Bye-bye.
Thank you.